And it works. Sweet. Got one thing that works. I tried the lapel mic just to see if it would record. And specifically, whenever I reserved this room, I said lapel mic with extra batteries. Today's just going to be one of those days, I think. Because the lapel mic is here, and it's dead, and there's no extra batteries. So, yeah. And like I said a minute ago, I lost the actual original presentation. It crashed on me. Like idiot, I'm not saving it up, so I have an older one. So I threw in a couple extra slides just to try to spice it up somewhat. But our objective for today, know what ultrasound is. Hopefully, I think I'll know that part at least. We're going to talk about what it can be used for. There's a lot of things. I think that's kind of the big point that I like to harp on, is all of the different things that it can be used for. But more importantly than that, not just like using it for it, because, okay, so we took an image, we took a picture, okay, cool, neat, whatever. We want to talk about how it can actually affect your practice, how it can actually do things, and how to get more information. So this is one of the ones that I threw in here, one of my new ones. This is one of the ambulances I used to work on in Kelly. I don't know if anybody else can see that, what it actually says on the side of this box. Okay. So I was hanging out with one of our ER docs not too long ago, and he made the joke about me, or about this. He saw an ambulance go by, and he's like, huh, it says mobile intensive care unit on it. What a joke. He's like, it's not an intensive care unit. He's like, it's barely even an ER. And for most cases, he's really right. He really is. We call ourselves this, but it's kind of a joke. We don't have any imaging capabilities. I mean, that's a big part of the ICU, right? A huge part. You got to know what you're treating. We got 12 lead. We have that. So we're kind of like an ER. We have a 12 lead at least. But that's a pretty new thing. But how can we actually become more of an ICU? How can we get our care to the point where we're evidence-based, we're actually doing critical things, we're actually doing critical intervention on people, and we're not just guessing anymore. We're not just saying, oh, well, look, this guy's got muffled heart tones, I'm going to stab him in the chest with a sharp needle. And that's not, I don't think that's real good critical care. That's not intensive care. It's not what we want to be. We want to be people that have evidence based on everything. We want to have imaging. We need to have imaging. And ultrasound's the only way we can get there. Ultrasound's the only way we can make this actually real. At least in my opinion. Because with ultrasound, I want to take us from here. This guy's a medic, right? He's got his bag, he's got his stuff. But is he very useful? No, right? To here. Okay. We got to get our usefulness back, and imaging, I think, is really going to be the way to do this. This is what ultrasound. So, I think the majority of people, I know most of y'all I've talked to, so you kind of know where I'm going to go with this. But I think the majority of people that are walking off the street, and you say, okay, I'm considering ultrasound in an ambulance. If they know anything about it, their response is going to be like, cool, fast exam, bro. Right? Because that's what everybody thinks it is. And that's what everybody thinks that we're going to do with the ultrasound is just the trauma exams, just fast exams. And we've got to go beyond that. We've got to unlearn that. We've got to start thinking about what we can actually do for people that is going to make a meaningful difference in them. Because in all honesty, the fast exam sucks. And I hate it. So, what the heck is ultrasound? Probably not that. Probably. Okay. So, just for the basic physics sake, to get through it really quickly, ultrasound is high frequency sound waves. I like to think of it like a fish finder. Fish finder doesn't work out of water. Well, ultrasound doesn't work without gel. I want to keep that in our head. It's just like a fish finder. And not just that, it's like a fish finder in the depth too. So whenever you actually get to looking at the images and looking at how it looks, I want you to think of it like a fish finder. The surface of the lake is up at the top where the boat is. And down at the bottom, that's the base. That's where the bottom of the lake is. And it's just like that with the ultrasound. The near field is at the top, and the far field is at the bottom, just like that. So if you have your head, it's a fish finder. It'll work really well for you. There's not any ionizing radiation. There's no bad stuff. It's not been shown to cause any harm. And I'll say that whenever I start talking about the OB-GYN ultrasound, I'm going to mention one area where there's a thought to be harm. And when I say thought, it's just a thought. There's not any evidence behind it. And I mean no evidence.
Is that what's referred to by the large American Radiology Tech Association on their page about, group POCUS or like non-radiology directed ultrasound?
You're talking about like a LAR principle?
Yeah.
Okay. So yes and no. A LAR principle is the as low as reasonably allowable or something like that. Basically, is use it as little as possible.
Okay.
That's the principle, and it's an overarching principle for all of radiation, for all of radiology, and it's because, they're used to radiation causing a problem. So there's a thought, at least, among some obstetricians that using pulsed wave Doppler to assess a heart rate on a baby is not a good idea, because a pulsed wave Doppler is a higher power setting on the ultrasound machine than some of the other stuff is. At least like the standard B-mode exam or M-mode exam is. That's a thought. So I'm going to teach you how to use ultrasound using M mode, how to identify heart rate using M mode because it's the lower power setting. And I'm going to do that not because I think that pulsed wave Doppler actually causes harm, because it don't, but just because I don't want you to get yelled at by some random dude in the hallway for being an idiot. I don't think you are, but they're probably going to call you that.
Isn't some of the question against some of the ultrasounds, et cetera, isn't that kind of more focused on the random 3D ultrasound places isn't that more where some of the attention is, at least on the OB side?
No, it totally is. I mean, that's kind of one of the other things is there's a recommendation against kind of doing what the Tom Cruise people did, that kind of thing, where they went out and bought their own ultrasound machine so they could stare at the baby all day long. Kid came out fine, didn't it?
Oh, I mean, it's Tom Cruise.
It's Tom Cruise kid. I mean, we can't help that part. But physically, it didn't have a giant hole in its head or something. I mean, it didn't have some big major defect physically. And yet we ultrasounded, not me, I had no involvement in that. They ultrasounded the kid every single day, or at least close to it, for most of the pregnancy. And everybody said, oh, that's a horrible idea. Kid came out fine. Okay? I'm not endorsing that. Please don't go do that. But what we do in the back of an ambulance in my opinion, has zero effect on the healthcare of a patient. Negatively. I don't think there's any way you can hurt somebody. There's a book in medical school we have to go through called Castano's Surgery Notes. And in one of the chapters on that book, it mentions there's physically no way to harm a patient with ultrasound other than picking up the machine and throwing it at them. Okay? This is a doctor saying this, and I agree with them. It's really, really, really hard to harm people. But I just want to point out that one caveat. When it comes to assessing fetal heart rate, I'm going to teach you how to do it with M mode. You can totally do it with pulse wave Doppler. And just in case you're wondering why I think it's fine, it's the same technology we use in the Doppler. Okay? That's what pulse wave Doppler is that. They're just not as smart, but it's the same power source. So it's been around for a really, really, really long time. Ultrasound has. Not as long as 1280 kgs, but it's been around for a long time. So emergency medicine started using it in the 1980s, and it was pretty widespread use after about 2000. Ultrasound fellowships have kind of sprung up. It's become a really big deal in emergency medicine. It's become really popular. And the reason for that, it gives us the ability to look at the patient right there, right then. We don't have to call an x-ray tech to come down and look at something. And that's all fine and dandy for it. But, we want to start talking about how to use it in an ambulance. And so whenever the first start on this was with Dr. Dave Spear in Odessa. He's the one who started doing that in 2000, I believe, yeah. And as far as everyone's aware, he's the first person to use it in a non-physician pre-hospital ultrasound system, or pre-hospital EMS system. And they used it for fast exams, and they actually used it as well to look at abdominal pain in women of childbearing age to determine if they're pregnant, look for the intrauterine strike, which is kind of cool. But not too terribly long after that, they stopped using it. Some of the other services that have used it, Keller, that was me, we did that. And on my last day there, my EMS chief asked me to pack up the ultrasound machines and send them back to Sonosite. So that was a whole lot of fun. Littleton, Colorado used it for a little while. I don't believe they're doing it anymore. Starflight Austin used it. I don't think they're using it anymore. I don't know. They may be now.
So,
Herman Lifeline, you actively still.
Herman Lifeline still does, yeah.
so why are places getting, like, if it's so great, why are places getting away from it?
That's an excellent question. I'm glad you asked that. I think what happened with my place and what happened with Odessa was a lack of planning, a lack of foresight. And unfortunately, in the wonderful, most glorious PowerPoint y'all would have ever seen that got deleted, it was amazing. It was amazing. I can start talking about it because you've never seen it, but it was amazing. I had some cool slides that talked about this, but basically I'll try to go over it if I had. There was a lack of planning, and that was the issue that happened at my place, and that was the issue that happened in Odessa. And that's one of the things I wanted to talk about to try to prevent it from happening again. Whenever you go to try to start an ultrasound program, whenever you're wanting to do this, you really need to take a second and do a self-assessment. You need to think about your own system and think, is your system ready for picking up ultrasound and doing this? So one of the things that we didn't do right off the get-go with our system was we didn't involve the hospitals. We didn't involve the hospitals that we transported to. We didn't have a super close tie with them. We had a decent tie with them, but we didn't have a super close tie with those hospitals. And that's something that I feel is really important for any system that's wanting to do ultrasound. You need to develop that tie with the hospital. And the reason for that is this is an imaging modality. Sure, there's a few things that we can do for these patients based on this, but a large majority of the big effect that we're going to have on this is that we're going to be triage. We're going to be early triage. We're going to identify things that need to be fixed in the hospital, maybe not even in the ER, but we're going to identify things that need to be fixed in the hospital. And the only way that us doing something and it having any impact on the patient care is if the hospital listens to us and believes us and they trust, the ER doctors trust that we know what we're doing, good enough to put their name on it. Because when we call in and say this patient has a positive FAST exam, let's act like I actually like FAST exam. So let's say this patient has a positive FAST exam, okay? Whenever we call into the hospital, they're going to have to believe that, and they're going to have to notify the trauma team on that. So they have to trust that you know how to read that, and you're not just reading urine in the guy's bladder and thinking that that's the free fluid and it's just pee. Okay? We don't want that. We don't want that. And if someone is very hypotensive and shocking, and you're trying to say, hey, he's got some, inferior wall motion abnormalities, his 12-lead EKG looks okay, but he's got wall motion abnormalities. I think this is an end stage that's going to progress to a STEMI. He just doesn't have 12-lead changes yet. Okay? If we see these wall motion abnormalities and you want to call it in and make a big deal about that, that's cool, that's awesome. We can really do that. But it's not going to make a bit of difference if the ER docs don't believe you, if they don't trust you. And even if you wanted to be more simple and just say, this guy's sick, he's really sick, I'm looking at his heart and it's not beating right. I think I'd like you to have a repeat ultrasound when we get to the ED. That was what I did. I'll just let you know. That was like my majority. I didn't go all nuts with it. I would just say, something's wrong. I know what normal is and this ain't it. Please recheck it for me. That was pretty much where I was at. Then you would at least hope that they would meet you with an ultrasound machine. So that's the first thing. Have a good relationship with your emergency department. Now, we developed one later after the fact, but man, it would have been a whole lot easier if we had that beforehand. Had we involved at least some of their staff, some of their nurses and ER docs into our training, we could just invite them to the training. Just come on in. Make it open for everybody. That way they know what we got trained on. I think that'd be very helpful. Whenever we call in a report, for the first few months we were doing ultrasound, we'd call in patient reports, and I'd tell them an ultrasound finding. If I had it, I'd tell them. But who are you talking to on the phone when you call in a report?
Nurse.
A nurse, right? I'll tell you from an informal poll that I did, asking around some of the nurses, I asked them, what does a FAST exam mean? Why do we call it a FAST exam? A pretty good chunk of them said, because it's done quickly. That's not knocking nurses. They know what they're doing. It's just ultrasound's not part of nursing school. Okay? So we don't want to knock the nurses. We want to bring them in and teach them at least enough to know what our exams are called and a basic idea of what they're for. Just a basic idea of what they're for. So that whenever we call in, you don't get the response I got of, okay, write it down. And then when you get there, nobody even knew that you did it. And they just assumed that you were talking about some weird thing you were doing with the pulse Doppler, with your Doppler, like fetal heart monitor thing. Because that's what they just assumed, because they just knew there's no way ultrasound's on an ambulance. That doesn't happen. And it's not FAST exam, that's the only word I know. Again, not knocking them, we just need to train them. So having them involved, I think, is a really big deal, and that would help a lot. You want to get, again, still thinking about yourself, your own service. You want to think if you're ready from your end, again, with the hospital of 12 leads. Let's talk about 12 leads. Very similar technology to ultrasound, okay? So, good question to ask yourself is, when I have a STEMI in the field, and I notice that it's a STEMI in the field, will they activate cath lab for me? Because if they won't do that, you're probably not going to get real far with ultrasound with them. Because 12 lead's been around a whole lot longer than ultrasound has. So that's something you probably want to think about. You know, maybe work on that first. You know, it's been around a whole lot longer. And the next question you say, okay, yeah, they'll do it, but only if I send them a 12-lead EKG. Well, one of these days we're going to have ultrasound be able to be transmitted. They're working on that in Southern California. They've been doing that for a while. I think it's Philips and Qualcomm. I think it's the two companies doing it. They've been working on it for about 3 or 4 years. It works, from what I hear. It's actually working, but I don't think it's ready for prime time yet. Maybe soon it'll be there. But at least right now, we can't do that. At least not without taking a picture of it and texting it to them. We can't do that. So, again, you want to foster that relationship. It all really does come back down to that relationship between you and the hospitals. And then think about your own service from your medical director's side of this, okay? Let's say you're the medical director. Do you trust your guys to do RSI? That's a question, right? Because if you don't trust your guys to innovate, to do RSI, to do a risky procedure, that's controversial. You don't trust your guys to do that, but they're well trained enough to do that. Do you really trust them to do some of these weird ultrasound things? They have even less evidence behind them than RSI does. I think they're cool. I think they're really beneficial, but that's just my opinion. There's not a whole lot of evidence behind this EMS ultrasound thing. So you're going to have to put your butt out on the line and say, yes, I do trust my guys. I want them to do advanced things. I want them to be cutting edge, possibly even beyond that. So think about it from your end on that. And then lastly, this is the part nobody likes to talk about, is the money aspect. Okay. You have the money to do this. Machines are expensive. $15,000 is about the minimum entry price. Minimum. Average is closer to $30,000, $40,000, sometimes up to $50,000, $60,000 per machine. It's one machine. We get the probes. Probes are about $5,000 each. I recommend 3 of them, 2 at a minimum. So it's expensive, and that's just the machines. You want to talk about training your guys? Their time's worth money, right? You got to pay them. If you want these people to at least like it, because the last thing you want to do is what we did. Force them to do this stuff. Tell you this much, you force firefighters to do things they don't want to do, they're not going to want to do them when they're done. I mean, that's for sure. So definitely think about that. You know, do you have the money to pay these guys for their time so that they go to training and they don't feel like they're being forced to do it, so that they actually don't hate you after it whenever you're done? So make sure you have the money for that. I did some quick math again in that wonderful slideshow. I did some quick math on that. Let's say you have 6 guys who are going to train to ultrasound. 6 of your medics are going to train. And so what you would want to do then, if you're going to do a really comprehensive ultrasound thing, probably a 16-hour class from the get-go. 16 hours worth of training is what you'd expect. So you have to cover their shifts and pay them overtime to come to the class, right? So 16 hours for that, and then over the next year, maybe 3 or 4 more little 4-hour here and there refreshers, just to keep it fresh on their mind. That works out to about $11,000 in wages if they make it to $18 an hour. So, have that number in your head. 6 guys, about 11 grand, 11, 12 grand, something like that. That's just for the first year. Not to scare you off from it, but you just want to have your ducks in a row and get ready for it. So that you don't get your machines in the mail and then be like, oh God, I have no money to train anybody. Because that's happened before. So, how do you know? Last time EMS. You have the machines. to do training. They're one of the first people to buy them. Can't blame them. It's just something that just wasn't brought up. You talk to the ultrasound manufacturers, what do they tell you? Oh, yeah, we'll send somebody down there to teach you how to do a fast exam. That's all you're going to use it for anyways. I've heard that from many of them. Deployment models. This is another good thing to talk about. And again, I apologize that I don't have any awesome slides to really kind of point this out, but deployment models. So, I just talked about how expensive this was, right, to do this. It can get a whole lot more expensive if you don't deploy them effectively, though. Or it might even be to the point that you don't think you can pull it off and do it. So the most common deployment model that I hear from EMS, because we don't have much money, so we normally end up with one machine, right? That's about the normal way it comes up. You end up with one machine. What they normally do with that is they'll take that one machine and they'll put it on a supervisor's truck. Or they'll put it on a chase car or something like that. But basically, they'll put it in the back of an SUV. In my personal opinion, that is the absolute worst thing you can do with the ultrasound machine. If that's what you're planning on doing, send it back. Your program's going to fail. You're not going to be happy with the numbers you get with this ultrasound machine if you do that. That's my personal opinion on that. So then you could come back to me and say, well, I can't afford to put it on every truck. Probably right. Probably couldn't. I don't even think that's a good idea. We tried that. Didn't work. We put it on every truck. One of the issues with that, if you put it on every truck, is you're going to have people that don't want to do it. Now you're setting the standard of care to the point that they have to do it. Is that a bad thing? No, but they're not going to want to do it. Your numbers are going to go down. Your program's not going to be to the level you would expect it to be or hope it to be. So you could say, okay, I've got 6 stations. I'm going to pick 2 of them and put an ultrasound machine in each one of those. That's not a terrible idea. It's not a terrible idea because then at least you can focus all your training and resources on those 2 stations and get them really good. You can do that. But you're still going to have people that are just randomly happen to be stationed at that station or at that ambulance or whatever way it is like that don't want to do this. So I thought long and hard about how the best way I think would be to do this, especially in a private EMS service or something like that. I think would be to actually have a team of people. Have people that you go and approach and say, do you want to do ultrasound? Are you interested in ultrasound? Are you interested in something cool? Whatever way you want to market it, just ask them if they're interested in it. They say yes, they get to be part of the team. So now you have a handful of people. It doesn't even matter if they're specialists, if they're new. It doesn't really even matter. Heck, they could almost be EMT basics for all I care because this stuff is easy. It really is. It's just different. But just people that want to do this, people that want to go to the trainings, that are interested in doing ultrasound, that will actually care and will actually think to pull this machine out of the bag and use it on a patient. That's what I would think you would want to do. I think that would work out best. Because that's all it ended up being. I trained 52 guys. I had 52 guys in my fire department. I trained 52 guys to do it. And about 10 of them used the machine. I could have just took those 10 that were going to use the machine and trained them a whole lot better and not wasted my time on the other 42. Because the point is, if I get 10 people that care about this, that want to use ultrasound, and then they come back with all these success stories, and they start looking good, and they're taking care of the patients good, what do you think those other 42 are going to do? Next year, when I get another budget coming around, and I ask the question, who wants to ultrasound? And we get a couple more hands raised, right? It doesn't cost you any money to do it that way either. It's not extra. You actually save some money, because you're only training 10 guys, not 52, or however many is in your group. So that would be what I would suggest when it comes to deploying an ultrasound machine. Think about it like that. Try to create a specialist team of these people. It doesn't matter what truck they're on. When they come in for their shift, they go pick up their ultrasound machine from whoever's on the team that's leaving and getting off their shift, and now they have their machine. It's their machine. The thing's going to be charged. It's going to be clean. It's going to be taken care of. It's not going to be dead the next time you want to use it, like it was almost all the time for us. These are real problems. This is not sexy, but this is real. If your leadership as well, and I try to say this as politically correctly as I can, if your leadership thinks doing new things are cool, but they don't want to put the time in to actually learn anything about it, they really don't care what it is, they just want to be in the newspaper, and that's their sole motivation for doing ultrasound, gotta help. You need to have your leadership on board because snags will come up. It costs a lot of money. I already mentioned that. The snags will come up. Issues will come up. People will not want to do it. People will sign up for it and then decide they don't want to do it. It's too much work. Your leadership needs to back you and say, this is a project we're doing as a department, as a team. Your leadership needs to be on board. Our leadership was not on board all the time. So that's another thing that can cause a problem. So, I know this is a wonderful way to open this talk up on all the things that can possibly go wrong with it. But think about this, I think these are all some problems that can be solved, problems that can be overcome. But it's really hard to overcome a problem that you don't even know is going to be a problem. So, think about this wonderful, wonderful stuff. So, fast exam. I keep mentioning I hate this exam, but you have to know how to do this, okay? You have to know how to do this. I can teach you how to do all these other ultrasounds, but if you can't do a fast exam, no one's going to trust you. And it's just that simple. If you talk to the ER guys, the experienced ER sonographers, most of them will tell you they hate the fast exam too. But it's just one of those things that we all have to do. And then occasionally you do it, and holy crap, you found something awesome. Holy crap, it actually is cool. If you're wondering why I hate the fast exam, there's really nothing wrong with the exam itself. It's actually a really good exam. The thing that I hate about the fast exam is the fact that you can't change human psychology. And that becomes the problem with this exam. This exam has a horrible negative predictive value. And what that means is that a negative fast exam doesn't mean jack squat. A positive fast exam means something, but a negative fast exam doesn't exist. That's not a real thing as far as statistics are concerned. Because a negative fast exam could be that the patient just doesn't have enough blood yet for you to see. Or it could mean that they're fine. Or it could mean that you suck at ultrasound. It's possible. Or it could mean that it's clotted, so it doesn't look the same, so you didn't pick it up. Or it could mean that maybe they haven't started bleeding yet and they're going to bleed later. But regardless, you don't know. They could be fine or they could be dying. That all lies within the negative fast exam. That's a big difference. It was an awful exam because of that. Because I can tell you this. I can tell an ER doc this. ER docs know this. And yet when it comes to the decision making on a patient, of does this patient need to go to surgery or not, they can know that a negative fast exam means nothing. And I will still hear them say, oh, I think he's okay. This fast exam was negative. Because you can't pull that out of your head. I'm saying this, I'm blaming them. But I did it too. You can't pull it out of your head. When you're thinking quickly, you put that stuff in your head and you think a negative exam means a negative exam. And it's awful because of that. Positive means something. That's cool. The other issue that I don't like with the fast exam is it doesn't change much care. Most of these patients are sick. You can tell that without the exam. That's just the honest truth. You have someone that got run over by a car. Are they going to go get a CT scan? Yes. Does it matter at all if their fast exam was positive? No. They're going to get a CT scan. So, basically, and by the way, in case you didn't know, focused assessment with sonography for trauma. That's why we call it fast, not because it's quick. It's fast. It is fast.
Hang on 1 second to change it. I should never change this slide like that.
Okay. I can send you this if you want. That way you don't have to type them all.
Sure. I'm still going to type because it's how I.
Okay, and that's fine. That's fine. That's fine.
But okay, I'm good.
I can send you that.
Thank you.
I can't send you the most amazing slideshow I've ever made, though.
Really? Tell me more about that.
But you can tell us like a tribute of it.
It was an amazing slide. It was the most amazing slideshow.
I started thinking it never existed.
It's not happening. It may not happen. No one else has seen it. Exactly. So the fast exam, it really does only take 1 to 2 minutes to perform. You know, the biggest thing when I try to get this stuff set up for research, whenever I try to get approvals for research, try to get my medical director to sign off on letting me do this, everybody's like, you can't delay transport. I don't want you to delay transport. I don't want this to slow anything down. That's the whole thing is these stupid medics are just going to sit on scene and just tinker toy with stuff forever. No. So in my protocols that I wrote on this, we put down that you can't do ultrasound unless you are transporting. With the caveat of the only way that you could get out of that was if the ultrasound would be used to decide where the patient went. And then we later added in, or you're doing ultrasound guided ID, because it's impossible to do ultrasound guided IDs when you're going on the road. I'm sorry, I love ultrasound. It works so good going down the road. You can't do it. I just don't think it's possible. If someone can do it, please send me a video of it. I would love to see this. We were talking about this last night. The way that I'll liken it to it, and only the firefighter will get this, unfortunately, is like if you're trying to couple a hose together, one guy's got one hose, one guy's got the other hose. That's impossible to do. You can't do it. The trick is somebody's got to look away because you're both just going to be doing this the whole time. And that's what it's like trying to start an IV going down the road. So that was the other caveat. So basically, you couldn't do the ultrasound unless you're transporting, unless the ultrasound was going to decide where you went, or if you had to start an IV. The other thing was the whole exam can't last more than 2 minutes. It can't. If it does, 120 seconds has come by, close the machine, put it on the shelf, you're done. I just didn't want everybody wasting all their time doing that. There's other more important things to do. And the cool thing was, we never had to do that. We never hit that 2 minute mark. It was pretty quick. Once you do this, you will probably need a fast exam done in like 60 seconds max. Max. I mean, it is a very, very fast exam. Now, this slideshow, not the awesome slideshow, but this slideshow is from about 2010, and that was the number that they had back then. If you listen to MRAP, you'll hear those guys talk about like 300-400 cc's depending on the user experience and things like that. That's doctors. We're medics. I'm going to say 500 and just leave it at that. That's what I'm going to go with. So this is part of that negative predictive value issue. If you have 485 cc's of blood, it's going to be negative. You're not going to see it, most likely. That's half a liter of blood still almost, right? It's not good. By the time you get to the hospital, it's not good either. And we had that. We got burned on that. It's one of the reasons why I hate it. When the first time I did a fast exam, we had she was 16 years old, got bucked off the horse, and then the horse like backed up and stepped on her, right on her rib. Okay? She had chest pain. Well, yeah, you got stepped on by a horse. I'm sure you're gonna have chest pain. You probably had some broken ribs. And but she seemed fine. She was stable, and, some chest pain, that was about it. So did a fast exam on her, it was negative. I'm like, sweet, we don't have to go to the trauma center. The trauma center's 45 minutes away. The closest hospital is only 15 minutes away. I'll be back in time for lunch. I mean, that's nice. So that we used it to prognosticate. So we took her to the closest hospital that was not a trauma center. What do you think they did?
Fast.
No, actually.
Scanned her.
They CT scanned her. It was positive. They flew her to the trauma center from that hospital. Because unfortunately that hospital was the other direction, so it was like now an hour away. So they flew her to the hospital. Now I'll tell you, she got discharged from the hospital the next day. They didn't do a damn thing for her. But what did we look like? We looked like idiots. We looked like we didn't know what we were doing at all because of that. So I don't like it. Just don't like it. So it's 4+1 views, the cardiac view. Okay, this is the one we care about most. Okay, at least me. I care about this one most. And then I care about the lung view, the second most.
Hey Jason,
Yeah.
I've got a question. Any thoughts on serial fast exams to increase sensitivity?
Whew, I didn't know it was on the internet.
Oh, hey,
Cool.
we're live casting it, by the way.
Neat. It's futuristic and fancy. Good idea. Okay. Yeah, you can totally do serial fast exams. And this is the thing. I'm saying this for services that are getting this stuff off the ground for the first time, okay? So going back to saying that you have an awesome relationship with the hospital. Let's say that you and the hospital are like best buddies, okay? You've got a really good relationship with the ED docs, they trust you. In that case, fast exam is awesome because it can be used to prognosticate how bad the patient is. If the fast exam is negative in the field and they believe that you actually did it right, And then when they get to the hospital, it's positive. This patient is now actively bleeding. They're still bleeding. It's getting bigger. Hey, that's a data point that we didn't have and wouldn't have had otherwise. So that's cool. But for the majority of people that are getting this program off the ground, if your FAST exam is negative in the field and it's positive in the hospital, the first thing that comes to the ER doc's mind is not going to be, wow, I have a cool data point. It's going to be like, these idiots screwed this exam up and they threw me off by trying to give me a negative FAST exam. I'm angry. I'm not that angry, but that's the point. I mean, it's that if you have that trust there, if you have the training, if you have everything in place to do that, it can be a data point. There is usefulness to this. I'm just trying to be generally applicable. And in generally applicable, I don't care for the FAST exam because of that. There are ways to get around the shortcomings of it. But they're more complex and they're theoretical. I haven't tried it. In all honesty, I haven't heard of a situation where you have that close in time with the hospital that you can pull that off. So, cardiac exam, to me, is by far the most important. This is what's going to kill the patient. It's what's going to kill them right now. And this is what physical exams are going to have a really hard time picking up. Okay. So, what's Beck's triad? You remember this one? JVD, hypotension, muffled heart tones. Who the hell's ever heard of muffled heart tone? Okay. Me personally, I think every heart tone sounds muffled. Maybe I'm just going deaf. Maybe I've been around sirens too long. I think they all sound muffled. But let's just say that you feel like you hear muffled heart tones. What causes JVD? Let's back it up and make it a shorter question. Is that a short list or a long list of things that can cause JVD? A long list, you know? This patient could have CHF. They could just be old. We never deal with old people, right? That have other medical conditions and then get in a car wreck. That never happens. Never happens. All of our patients are all 18-year-old, like just joined the Army. I mean, they're just like perfect, right? No. We don't know if the JVD is new or not. Hypotension. Again, short list, long list. The point is, you get all three of these. Let's say you think there's muffled heart tones, you have JVD, you have hypotension. Cool, Bextrad's positive. Are you going to stick him in the chest with a needle? Are you that comfortable? Probably not. I wouldn't be. I wouldn't be comfortable doing that. Now, the way we got taught to do that was to actually go for the right shoulder. That way, if it was negative, you wouldn't hit anything. There's still things there. There's still things you're going to hit. Okay? So, again, goes back to, if we want to be in ICU, we need to have imaging, we need to know. We need to know what we're doing. We don't need to be making bad guesses on bad tests that have been around a really long time. We need to know. So, our physical exams are going to have a really hard time picking up something wrong with the heart. Tamponade being one of the big ones. Let's just say it's hypovolemia. That can be kind of a tough one to pick up sometimes. Look like PEA. Yeah. Our test can pick that up. Look at the heart, look at the IVC, both of those, you can pick it up pretty quick. That's an easy one to fix. And dealing with trauma, I know I'm kind of moving outside of trauma a little bit with that. Dealing with trauma, I know there's the big push, don't get crystalloids. I'm sad. That wasn't how I was trained. It's probably right. It just feels so wrong. It feels so wrong not to give them a couple liters of fluid. It feels so wrong. But for those services that carry blood, I think you could totally use it to identify who needs blood, I would assume. Pneumothorax, though, whew, this one is awesome. I can't tell you how many times I had people with chest trauma that I'm taking to the hospital, and they're just kind of sick. They're not like sick. They're dying kind of sick, where you just dart the chest, you're done. Kind of, I know it. They're just like, oh, is it a pneumo or not? I don't know. So many of those people, you spend so much stress, I probably lost a year or two off my life. Just a handful of patients taking the hospital, just going, oh, is it a pneumo? Do I need to be darting or not? You can just know. You just know. It's better than a chest x-ray. It's so good when you find lung point. You can prop that patient up at like 30 degrees, go find lung point, just trace it around with a Sharpie. And when you come into the hospital, you say, this is how big his pneumo is. They're going to look at you really strange if you do that. But you could. You could. His pneumo, it's right here. I drew it for you. You could do that. It would be weird, but you could do it. I mean, that is cool. I mean, that's just cool to me. Or you could just treat it. That's probably the better thing. You could just treat it. The liver exam, this one's an easy one to do. I like this one just fine. It's okay. It's easy. This one's not too bad. The spleen exam, a little more typical to the liver. It's a little more. The thing with the liver is it doesn't have any ligaments that hold it down to the retroperitoneum. So because of that, when you get blood in there, the liver will literally float off of the kidney. It just moves. Everything moves, and you just have to see that bloodstream. You have to see it there. That's called Morrison's pouch. It's not a real place. It's a potential space. That's what that is. And so it's awesome. The blood can only go there. I mean, it's just this one spot. So that's pretty cool. The spleen, on the other hand, that thing's anchored in all over the place. I'm not a school student. I should remember how many ligaments. I don't. But it is. It's got a couple of them. Okay, it's the few, more than two, like 3 or 4. It has ligaments that hold it down. It's not really going to move. So you got to look at it a little better and kind of have them take a couple breaths. And then you might say, oh, there's the blood. It's just not going to jump out at you like the liver is. Not that's a bad thing, but just be aware of it. The bladder, on the other hand, this one can be easy, and it's also, and at least this is what I've heard, more likely to be like the first one that comes positive. So it's be an earlier predictor. It's really easy to get screwed up in that, especially in males. But there's, okay, that's what females do, but with males, we don't have quite as many landmarks, so it's kind of hard to see what you're looking at least for an inexperienced or novice sonographer. For females, there's a little more landmarks in there, so it's not quite so bad. But then the issue with females is, depending on what time of the month it is, they may or may not have free fluid in the pouch of Douglas, which is just behind the uterus. And that's physiologic, not pathologic. There's nothing wrong with that. So, something to be aware of. There's some things that can trip you up with that. There's lots of things to trip you up with the FAST exam, but we just don't care for that quite as much, just because, at least for novice sonographers, there's some issues with it. So, I mean, if it was me, if I had to redesign the FAST exam, I'd want to like do cardiac, liver, and maybe extend it, and maybe this lane, I'd probably leave the bladder out, and then think about that one. But the lung and the heart, to me, is by far, that's your money. That's your money. That's where you're saving lives now. That's where you're actually changing the care of patients. The rest of the stuff, they're just going to need a CT scan. That's what they need. So, yeah, like I said, this is the older slideshow. Back then, I kind of called it expanded scope prehospital ultrasound because at least in the U.S., nobody I could find did it for anything but FAST exams. That's all they used it for. So I kind of like the idea of using it for more things. I alluded to that in the video that I started this off with whenever I was talking to Sonosite when they came out. Was the issue really was, it was more practicality. I had a free ultrasound machine that I was given for a few months to play with. And the city of Keller, where I worked at, had no highways. We didn't have any highways going in and out of the city. So we had no trauma almost ever. The whole time I was there, I think I can count on one hand how many bad traumas I had. So we just didn't have much. We had a lot of old people. We had a whole lot of old people. We had a lot of nursing homes. We had some sick people. Sick people. So I went back and hung out with Dr. Spear, the guy that gave me that ultrasound machine. I hung out with him in the ER a few times. It's like, teach me what you know. Teach me some of the other things you use the ultrasound for. So we started using it for some other things. Use it for hypotension. If you don't know what's wrong with them, look at the heart. And that's something Hennepin County Medical Center has been teaching for a long time. Every single one of their unstable patients, they ultrasound. Just the first thing they do. If they're unstable, if they're sick, they ultrasound them. And Scott Weingart now has the rush exam, which is pretty cool. I think back then we called it a fear exam. There's been a couple different acronyms for it. Basically, the principle is the same. If you don't know what's wrong, look at everything. Just look at it with the ultrasound machine. Just take a look. Very helpful. You can pick out a lot of cool stuff with that. Have complaint-based exams, don't pay. We look for AAA, we look for gallstones. It's not very useful. A lot of ER docs don't even do that, but you could. Through board, no long transport, good. Kidney stones, that's actually pretty cool. We did that. We did that. When I got BJ I was talking about, that was his first exam. He had a dude, had sudden flank pain, most likely kidney stones. So we took a look. It's positive. Does that really change a whole lot? Probably not. But at least you know it's not something else. You know, if you've got hydronephrosis, if that kidney is a big old swollen kidney on the side that they're hurting, that's their problem. You don't need to keep looking for other problems. So let's help with that. Spontaneous new rupture, we can do that. OB-GYN exam. Man, I thought that was worthless. I thought, okay, cool, OB-GYN. I don't want to be an OB-GYN. I don't care. They use that a lot in the ER. And if they use it a lot in the ER, you probably would use it a lot in the ambulance, right? So went ahead and learned how to do it. We were learning how to do gestational age, things like that. Actually look at the baby, tell how old they were. Said, oh, look, 20 weeks and 6 days or something. That's cool. That's the why. But we got good at looking at babies. So when I had an 18-year-old female that was 26 weeks pregnant that presented in active labor, what do you think we did? I mean, if you're presented with that patient, you've got a fork in your road, right? You're either going to say, this is preterm labor, we're going to give this patient tocolytics and fly them to the high-risk OB center, or this is spontaneous abortion, baby's dead, mom's just rejecting dead fetal tissue. It's one of those two things. It's more likely to be baby's dead. That'd be a bad call on your part if you just guessed that. The baby could have been saved. That's not good. That's not what we're here for. So we took a look. We knew how to guess him for age. So at least we're comfortable enough to be able to find the baby. And then took a look in there. Found the baby. It didn't have a heartbeat. So now we knew. Pretty simple. This baby's dead. There's nothing we can do to change that. So we called the medical director, called what we found. And he basically gave us permission to give the patient some morphine for the pain and take her to a local hospital. Saved her a $20,000 helicopter ride, all the risk associated with that, risk of tocolytics, emotional trauma, all the other crap with that. Basically, it's the right thing to do. It's right for the patient care. Absolutely no way to do that with an ultrasound. So you can totally use it for that. And then difficult IVX, so we harped on that for a while. I love it for that. It's really good. Preventative healthcare. This was kind of neat, but we had a lot of big plans with this, and some of them fell through, so I couldn't get to do some of the things I wanted to do with this. I had school athlete screening. We actually worked with Coach Children's and Fort Worth a little bit to try to get this set up. We were close to getting it done. But man, that would be cool to do. You can totally identify hypertrophic cardiomyopathy really easy in an ultrasound machine. And I think if the medics get good at cardiac exams, that's something they could do one of these days. Totally not ready for prime time, by the way, for everybody watching out there. But this is cool. You could do this. This could be where we went with this. Health fairs, look for AAAs. The reason I say this, I mentioned the whole AAA things to some of the guys in the fire department, and they went nuts over this. Because about a year or two before I started working there, we lost. I can't remember exactly how old he was. I want to say 24, 25. He was 24 or something like that. He was a firefighter that died. He left his shift, went out for his morning run, collapsed. The passerby saw basically a lifeless body in the road and called 911. They took him to the hospital. He had a AAA and ruptured. Is ultrasound going to pick that up beforehand?
Maybe.
Probably not. Right, and let's just be honest, they're probably not. But my captain had us look at every single firefighter for that. They like that a lot. There is some stuff in the literature and some family literature about using AAA exams and doing things like that in elderly patients that have the right risk factors. It's something that could be done. Yes, sir.
What about thoracic aneurysms? Like, is there an ability to look at that with ultrasound? And
You
how?
actually can.
Okay.
Actually, you can look at a thoracic aneurysm in that. I don't know the numbers,
Okay.
like on how sensitive or specific it is, but I've seen case reports and videos of it. And with that one, you generally will do at the jugular notch. You'll actually put it right here and look down. And what you'll see looks like a big vein going across your screen, and you'll see an extra flap in the middle of it. That's going to be the dissection. It'd be like it's a type A dissection. It's an ascending dissection. Is what that would be.
So like a DeBakey one.
Do what?
Like a DeBakey one. Off the ascending route.
Sure.
Okay. Sorry.
I probably should know that. I'm sure it's going to be on my step test.
I'm in a cardiac unit all day.
Yeah, I know. Yes, you can see that, and if I suspected it, I would totally look. I haven't had a patient that I suspected that, so I haven't had a time to try it out or anything. But I've seen some videos where people did that, and you can pick it up.
Okay.
So you can definitely pick up the thoracic aneurysm as well. That whole like pulse pressure difference in the arms. I forget what the numbers exactly were, but it was abysmal. It was like 15% or something positive predictive value. I mean, it was just why even bother? Why? So anyways, you could totally do this as a preventative care thing. And that was something I wanted to do. We had this thing called Color Fest every year where the city like threw this big party or whatever. People would come by and we'd take all their blood pressure for free and all this junk. It was a really big thing. It was in the newspaper every year. And I mean, there's just so many things. If you have ultrasound and you're willing to train your guys and you're willing to have them do this, man, this is an awesome PR idea. I mean, this is the way to get your bonds funded or whatever it takes to get your ultrasound out there. I mean, this is the way to do that, is this good health things. And it's probably not something that most people think about. There's not a whole lot of research behind it. There's certainly no harm, but for someone that wants to do this, wants to put the work in, wants to figure out how to do all this stuff, there's a lot of things ultrasound can do. Carotid CMT measurements, all the machines can do this. It's just something you can do. It's pretty cool. It's kind of like an ankle brachial index, a way to detect peripheral vascular disease. It's something you can do, but just not all machines do that. Just be aware of that. I don't know, like if you think that your 1995 is on the side 180 or something, that it will do it, it won't. Like I said, I kind of back it up just a little bit because this is the old slideshow, so there's actually a bunch of new things that have come along now that ultrasound useful for even more than what I had back then. Talk about lung ultrasounds for just a second. Not only can you identify pneumothorax, which is nice and cool, but you can also identify the difference between wet and dry lungs. It's pretty cool, huh? I mean, the way I got taught to look at this is if you have a patient that has undifferentiated shortness of breath, especially if they have a history of CHF and COPD, which we never have that, right? We never have patients that have combined problems like that ever. You try to look at their feet and see how much fluid they have. Well, that's a sign of right heart failure. I know it is a semantical thing to get into the difference between right and left heart failure. I understand that. But just the point is that just because they have fluid in their lungs doesn't mean they're always going to have fluid in their feet. But that was all we had. Is generally if you give someone with CHF albuterol, don't know, but it's kind of a guess, that's not a good thing. It's not the best thing, at least for them. It'd be better to give them nitrates without that. Same thing as if you give an asthmatic nitrates, and you're just going to give them a headache and not make it any better. COPD or whatever you want to say. So, kind of cool that ultrasound, you can actually look at the lungs and see if they're dry or wet. You'll see these things called A-lines, which I got videos of this, pictures of it when they were in that wonderful slideshow that I was talking about. Basically, you can imagine it's like this pleural line that's just repeating down because of an echo off of a dry pleural membrane. So the whole thing is just repeated down. So you have these horizontal lines. Those are A-lines. It's a normal lung, or at least a dry lung. A wet lung, vertical lines going down. To me, it looks like if you were under the ocean looking up and the sun rays are coming through. That's what it looks like to me. Beautiful picture. But that means a wet lung. That's some of the sound waves are actually penetrating through the lung. They're not completely getting destroyed by the air. That's the physics behind it, at least, is that some of them are getting through because of the moisture in the lung. So your B lines. And if we want to go another 5 years, 10 years into the future, you can actually pick out the difference between viral and bacterial pneumonia with this. You can pick out pneumonia and then viral versus bacterial pneumonia with this. It's pretty cool. Not ready for prime time either, but man, that is cool. One day when we get antibiotics on the ambulance, you can actually do it for a real indication. Now you're in ICU. Now you're a mobile ICU. You're not just throwing antibiotics at things that stick. Oh, heart exam. Just talking about the heart exam earlier. You can pick out sepsis with this now too. I saw a paper not too long ago, hyperdynamic heart. It's actually pretty specific for sepsis. It's pretty cool. Okay. So, how will ultrasound help my EMS? I think I've been harping on that for like the last 20, 30 minutes. Basically, fast exam, if you have the perfect world system, it will allow for earlier notification and a need for surgery trauma. There was a paper that came out not too terribly long ago that talked about how is ultrasound useful in thoracic trauma. And they noted that pre-hospital ultrasound changed the treatment course for patients, for these thoracic trauma patients. Changed it. They didn't say that more patients survived. They didn't really say that, but they said that things changed. The one caveat with this was these were physicians doing the ultrasounds. So, actually specifically said, it's unknown what the effect of non-physician ultrasound or sonographers would be. I think, again, it comes back to that relationship you have with your hospital. I'm going to keep harping on that. That's what it comes back to. If your docs don't trust you, it doesn't affect the patient care. It doesn't. That's what that is. It'll detect a pneumothorax and tamponade. Now, this is something you don't need anybody to trust you on. You can do this, at least if you have a scalpel-sized needle, you can do that. But people, you can do this. You don't need someone to trust you. So this is the low-hanging fruit. These are things we can actually pick out and do. Significantly improves OB-GYN care. I've got some cases I'll go over. I already went over one, but I got some more cases. This is awesome. It actually does things. I didn't think it would, but it does. It will decrease the number of IV access attempts. It will do that. It's very good at this. Plus, that ended up being like half of our ultrasound uses. If you want to go back and justify having your ultrasound machine to someone, this is going to double your numbers to do the IVs. And it's good patient care. It's going to double your numbers and it's good patient care. Plus, it gives the guys practice with the ultrasound machine. I mean, it's just doing IVs with ultrasound. That's where it's at. That's your bread and butter. At least it should be. And the preventive medicine aspect, I mean, that can be cool. It's not yet. I'll admit it. It's not a real thing. It's not fleshed out yet. But man, that could be cool. That could help you fund your system if that's what you wanted to work on. There's some low-hanging fruit there. There's some stuff there. And I'm holding out my favorite thing. I'm holding it on.
What's she screaming about? Nothing she can do.
That was bad.
Yeah.
Right? Say it's your patient. What do we do?
Constant.
Yeah, exactly.
Drive slow.
We get these people. We get these really sick people. Is ultrasound going to change whether or not that dude goes to CT scan? Not at all, but it will actually change what you do for them. You can identify fractures. You can get your IV with ultrasound. You can determine if they have a pneumothorax. You can determine if their heart has ripped off of their aorta. Whenever they die in your ambulance, you can use ultrasound to help prevent delays so that you don't have to do pulse checks. You can actually do the pulse checks while you're doing CPR. Okay? Ultrasound will help you with everything with the management of that patient. Absolutely everything. Oh, and a fast exam. I put that last, sorry. So, back to the OB stuff. Now that we've gotten our fast exam out of the way. Back to the OB stuff. So, this was my first use of ultrasound. I say first use of ultrasound. The actual first use was BJ's use of hydronephrosis, looking for the kidney. That was pretty cool. My first use of ultrasound with it was at about 2 hours after I'd done the initial training on guys like this with the whole group of everybody. BJ's wife was a sonographer, by the way, so we actually already knew how to do some of that stuff. So I had a 30-year-old female that was gravid at 8, power 1, had shortness of breath, 20 weeks gestation, so she's too young to deliver. And I'll just put it this way, she was freaking out. She was flipping out. We picked her up from church, and she was very, very worked up. She was breathing quite rapidly. Actually, sounded like she had some wheezes, She actually sounded like she might have something going on. And so we're talking with her, and she's expressing her concern about how many miscarriages she's had, and the fact that she can't feel the baby move, and she's freaking out. And so we go, hey, we got an ultrasound machine. Let's take a look. So we took a look, and we could see the baby, and he's in there going, ooh, 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 doing his thing. I mean, he's just going to town. He's moving his arms, got a good, fast heart rate. We're able to see the heart rate, count it, tell the mom, and then turn the machine around and show it to her. Say, here, Mom, do you want to hold the probe? Look at your baby. That respirations went down to 12. She had good, clear breath sounds. I mean, she was cured. She was cured. No epidural needed. That's cool. Then that's good patient care. It really is. Just giving her albuterol treatment, good patient care, taking her to the hospital, put her in a hall bed, letting her sit there for an hour or two till the ER doc can come by and then scan her. No, that's good patient care. To saving lives? No, but it's good. I actually already talked about this one. Okay. So, this lady, again, didn't change patient care too terribly, but it's still kind of an interesting case. Had a woman, you get there, gurgling respirations, Bowman pulmonary edema. We've all seen this. She's hypotensive. We had a good guess of what's going on. We could put the ultrasound machine on and see that her heart was just going. It was just barely beating. So we knew it was. We knew what it was. Heart failure. She's actually cardiogenic shock. She's in hypotension. But we knew what it was. Helpful. It wasn't a PE, at least. That much. It wasn't a PE. And again, severe shortness of breath, very similar case. Pulmonary edema, hypotension, 12 leaks of the lateral MI. Ultrasound said, yeah, that's lateral MI. Okay. Nice to have a confirmation. Not doesn't change too terribly much, but it's still nice. There's cases where you're not going to have that. Okay. This is the case that I sold myself on ultrasound, and I realized, oh, this is cool. This is going to do things. I had a 42-year-old male guy in a nursing home. He's about to be discharged. He had a leg infection, okay? That's pretty benign. Really strange that he's in a nursing home. I don't quite get all that much. But basically, the guy's about to go back home, okay? And the guy called for severe shortness of breath. And it was so bad, he was so sick, that we had to RSI him really quickly. I mean, he was not breathing. So we go put this tube in, and we go, And the guy that was bagging him goes, it's not working. Okay, he's supposed to get better now. And I mean, it's just that the air's not going in. What the hell? This is kind of strange. You start thinking, hey, is the tube in the wrong spot? I mean, wouldn't even do that if it was in the gut. So, pull the ultrasound machine out, look. Put it over here, and there's black everywhere. It's just all black. I'm like, this has got to be the world's largest tamponade. It's like the size of a beach ball. It must be. To be honest with you, I didn't even know what a pleural effusion was then. I didn't even know what it was. Okay. Move it over here, and I can see his heart beating. From here, that shouldn't happen. So I knew his chest was full of fluid. I didn't know what it was called, but I knew his chest was full of fluid. And that was his problem. So fortunately, we're about halfway to the hospital, and we'd already called and told the hospital this guy's in cardiogenic shock. We had 2 previous cardiogenic shock patients that month. You get 3 in a month. Oh, but, you know, well, we've been having. Coming through, right? Well, that's what we guessed. It wasn't that. We called him back and said, he's got fluid in his chest. That's his problem. I don't know what it is. He's got fluid in his chest. That's how much I do know. And so as soon as we come in there, ER doc standing in the hallway with the ultrasound machine. Puts it on there and he's like, well, this guy's got fluid in his chest. go. And they're able to tap it pretty quickly. And he actually did quite a bit better, very, very quickly. And it's got to be like the worst pleural effusion you can have or something. I mean, this is sick. Hopefully one day I'll learn what this is called, whatever he actually had. Made it so big. But basically, we picked up that what was going on with this guy. That probably would have been picked up at some point in the ER, maybe 15, 20 minutes later when they got the chest x-ray back or something like that. They would have picked it up. It would have happened, but we picked it up 20, 30 minutes earlier. And this guy was sick, 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 sick. It might have made it sometime. But there's just no way we would have ever picked that out otherwise. I already skipped at that point. So I had a guy in cardiac arrest, to kind of mention this. It was pretty cool. So we use the Lucas compression device, and the ultrasound machine will fit in. I've got some pictures of this, so I'll show you in a minute. The ultrasound machine will fit in on there. And what we noticed was, we're doing the pulse checks, and we're just like, man, this is taking forever. We're trying to be quick, and it's just taking forever to feel it. And I'm seeing almost instantly when we stop for pulses, I'm seeing the heart almost instantly. I can tell it's not beating. We got front doing pulse checks, and it's taking forever trying to find the pulse. So then we just stopping the Lucas. So, well, we could see the heart. It would just work while it's beating. It worked. You could see the heart. I could tell if it was beating or not. I could tell if it went into a shockable rhythm. And not just that, was when we got the guy back, I could tell when his heart would start to just kind of go back down. And when you needed a little bit more heavy. I'm not going to get into the happy thing. And we started on that, but that's what we did. So we could tell before he went back into rest. And then we could tell that it wasn't hypoglycemia, it wasn't a PE, it wasn't tampon, it wasn't anything that we could fix, it wasn't one of the HSNPs that we could fix. So that's